Welcome to the Medical Alley webinar series, Bringing the Future Forward. Today's program is sold out, and we thank the Medical Alley members and healthcare leaders from around the world that have joined us today. I'm your host, Shay Mandel, President and CEO of the Medical Alley Association. Today, we're talking on the topic of closing the health inequity gap through more inclusive clinical trials. And I'm honored to introduce our guests. To kick things off, Mike Mahoney is the chairman and CEO of Boston Scientific, and Dr. Michael Jaff is the chief medical officer and vice president for peripheral interventions with Boston Scientific. Gentlemen, welcome, and why don't I give you a chance just to introduce yourselves. Mike, why don't you kick it off?
Sure. Good morning, Shay. Can you hear me okay?
We can.
All right. Nice to see everyone. I'm not standing in the parking lot of our headquarters, but it's the cleverest background I can find, not very creative. It's great to be here. We've been part of this organization for many years, and we're happy to contribute as well as continue to learn from this organization in the Twin Cities area. So I've presented with this group a couple different times, so it's great to be here again. And thanks for dialing in today.
Thanks, Mike. Dr. Jaff?
Thank you, Shay. A real honor for me. My background is even less creative than Mike's, so I apologize for that. So I'm a vascular medicine specialist. I take care of patients with all aspects of vascular disease. Ran the vascular program at Massachusetts General Hospital for about a dozen years, then became the CEO and president of the largest community hospital with that health system, and joined Boston Scientific just about a year ago. And this is a passionate topic, so I'm excited to be here. Thank you, Shay.
Thank you. And everyone missed the beginning as we were chatting going into this. Tremendous respect going on between Mike and Dr. Jaff. So we are so happy to have both of you here and to talk about Boston Scientific. So Mike, I want to kick it off with you. And while we're talking today about inclusive clinical trials, to address the significant racial inequities in healthcare, you have to walk the walk and talk the talk first. So why don't you tell us a little bit about Boston Scientific's commitment to diversity, equity, and inclusion?
Sure, thanks. And we'll jump into the clinical trial piece in a few minutes here. I've been with the CEO for 9 years now, and like many companies, diversity and inclusion is one of our 5 core values that we have as a company. And that's nice that it's a core value, but what's more important is the action that you try to take and global leadership in this area, as it's certainly a journey. And we've made really nice progress, and I'll highlight a few areas, but it's certainly a journey over time. And we continue to try to improve and also learn from many other companies in the local area, Minnesota's globally, to try to strengthen ourselves. And we do it for a couple of reasons. One, we think is absolutely the right thing to do, to have a more inclusive and diverse team at Boston Scientific. And it also helps company performance. And we see that when we have more diverse teams leading projects, outcomes are better, ideas are more creative, more challenge and openness. So it's obviously the right thing to do for society, but also helpful, for our business. A couple of things that we've done. We've been pretty public about our goals in this area. And back in 2017, we actually made public our diversity and inclusion goals. At the time, we're really focused on 2 aspects. One is promotion of women to supervisor and director levels in the company, and obviously beyond, which we were underserved in that area. And 2, the representation of Black employees, which is also underserved, which is improved, but we still have improvement in that area. So one is we actually created specific goals in 17, and then we've actually updated those in 2021 called 3UP and increased our targets in those areas. And one reason we did that, like any business, when you set specific goals and make it a priority and measure it, then the teams find more creative ways to actually obtain those results. And that's embarked upon everything from us engaging very closely with the Black engineering colleges in the US, where we have a program in place now for over 10 years, and we bring on, approximately about 50 to 80 interns per year from those organizations. We've established great relationships with the Divine Nine, which is the fraternity Greek system within those organizations to help build our network, and many other activities. But we've seen when you set goals, like anything else, the team unleashes more creativity in trying to do that. We also do things that many companies do, enforcing diverse slates on our new openings, and encouraging our employees to take risks with those openings. The last thing I'll say, many companies do this, something called employee resource groups. And we have these across globally in Boston Scientific, everything from our Young Women's Network to our LGBTQ community to our Black, we call our Bridge ERG, to disabilities group. And we do this to provide a forum, a network for those employees, and also to spotlight the great business achievements. But what we've done recently, a few years ago, is we have each executive committee responsible for one of these ERG groups. And also in our performance reviews, we ask for specific goals in terms of inclusivity, engagement in this area. So we try to really bring these ERG groups to life, and not have it be a check the box exercise. So our executive team is very engaged. Obviously, Dr. Jaff's going to talk about our clinical group. We're pleased with our progress, but we have a lot of work to do, like many companies in this area still.
It is tremendous work. So Mike, I'm going to have you set the stage a little bit before we get into some more details with Dr. Jaff. So the challenges of addressing health disparities and inequities is really complicated, and every sector of healthcare has a responsibility to work together on this challenge. So how is Boston Scientific at the high level supporting this important work of addressing these challenges?
Sure, it's a complex one, and Dr. Jaff is going to talk about Close the Gap, and he's really uniquely positioned to talk about it, one as a physician and also as a hospital leader running Newton Wellesley Hospital. So we've seen it from all different directions. But from Boston Scientific standpoint, again, we make it a priority as part of our overall goals in diversity inclusion. And we all realize that the great healthcare disparities, and it's being even amplified by the impact on COVID. And we see it in our clinical trial results, where traditionally we had significant small percent of our clinical trials patients in the trial that have been represented by minorities. So we also see that there's a problem, and Dr. Jaff will talk a little bit about that. So one is we make it a priority, and two, we're shifting our metrics in our clinical trials to account for that. But Dr. Jaff will talk specifically about Close the Gap. What's great about this is an initiative that was, I think, over 15 years old, and actually established by Guidant, pre-Boston Scientific acquiring Guidant. And it was a great practice that the Guidant employees created. And since that time, we've poured more investment and fuel on Close the Gap. And I think Dr. Jaff can talk a bit more about that program.
Well, let's do it, Dr. Jaff. So Mike has mentioned several times Close the Gap. So can you tell our audience more about the program, some of the challenges you're addressing, and how that increased diversity in clinical trials fits into the program?
Most definitely. So first and most importantly, this is not an initiative that just started as a result of the social unrest that plagued all of us last spring and summer. It's 15 years old. So it's part of the company's reason for being. And I think what happened with George Floyd's murder, in which many Boston Scientific employees were personally affected by that, given the presence that BSC has in the metropolitan Minneapolis-St. Paul area, we felt it was important to take an even larger stand. So there are 5 pillars of this Close the Gap initiative, Shay, that we pay attention to: community, economic empowerment, education, government policy, and then the one that I am honored to be asked to lead across the company, disparities in healthcare delivery. Now, this last one that I want to focus on really brings to the fore this issue of changing clinical trials. Now, the reason to do this is not just to say, hey, look how much better we've gotten at expanding the pool of patients getting involved in clinical trials. The outcome of this is that care that's really valuable, that has been shown through randomized clinical trials, large international registries, actually gets to everyone who needs it, not just for a select population. Now, in order to do that, you've got to be very deliberate. There are lots of obstacles to this. Some are historic. The lack of trust that underrepresented minorities have in clinical research, and quite frankly, rightfully so. Secondly, it's got to be a relationship with their doctor, their nurse practitioner, their physician's assistant, because that's where the trust lies. They become part of that patient's family. And honestly, Shay, it was the most fun part of practicing vascular medicine, is being part of a patient's family, going to weddings, going to celebrations of new additions, going to funerals, and really being viewed as part of the family. That will not happen if a company goes out and puts up a billboard saying, hey, enroll in our clinical trials, it's a great product. It only happens when there's confidence with the care provider and the patient. Now, many of these doctors, nurse practitioners, et cetera, really don't do a lot of clinical research. And so it's the ability to open their eyes to the benefits, to expand opportunities to care for their most sick and at-risk patients, that they then gain skills, they gain experience, they can provide that to their patients. And oh, by the way, it helps their careers. They can start to publish if they like. They can present data at local, regional, and even national symposia. And that's great for doctors and other care providers who are interested in that. But most importantly, the community starts to hear about this. They start to see the value of enrolling in clinical trials to access great new technologies and new therapies that can truly change their lives, let them live a longer, healthier, safer, and productive life. And so it's an amazing opportunity, Shay. And quite honestly, we've taken what the COVID pandemic has underscored and ran with it quite aggressively to push forward on knocking out healthcare disparities.
That's what leadership's all about. Well, I know you have several partners also included in Close the Gap. So you kind of gave us an outline, Dr. Jaff. And so I'd ask you and Mike, jump in, talk about the importance of collaboration and partners and why this has been so critical to the success of the program.
Well, you're totally right. This is a problem that has been present for decades. I know that Mike comments often about how Boston Scientific clinical trials have not included large proportions of underrepresented minorities. But to be totally transparent, I've sat on 5 different National Institutes of Health steering committees for major national and international vascular device trials, where our intent before we enrolled the first patient was to have a significant proportion of enrollees being underrepresented minorities and women. And we failed every time, not because we didn't want to, but because we didn't think it through well enough. We didn't have the partnership collaborations to make it work. And so you're right, partnerships are everything, from local hospitals who care for the patients that we want to get in trials, to national patient advocacy groups, to professional societies like the Association for Black Cardiologists. I mean, this is an amazing, rich opportunity to get everybody aligned on the same focus. Mike, comments on this?
No, you're absolutely right. We can't do this alone. We want to partner with the local hospitals. As Dr. Jaff said, we have tools that we share with the executive teams, hospital administration, that will break down their demographics, what their patient mix is, and where they're seeing underrepresented patient groups that hopefully help light a fire with the hospital association. And also we work locally with the hospitals there, because you have many doctors who are very passionate about this, as Dr. Jaff said, and everything from partnering with the local YMCA to Red Cross for monitoring services that we'll provide we've been to local concerts and local fairs. And so this is not an effort to sell a Boston Scientific product. Our products are pretty far downstream, but it's really to raise awareness. And so these patients can seek treatment in a way that I not only bring more awareness and education to them, but as Dr. Jaff said, have them more comfortable and engaging the local communities and recognizing these disparities and partnering with anybody, whether it's the hospital, competitors, others, to try to bring more awareness and drive more traction to bring these patients through.
You both mentioned this has been a long journey. So, and I think that's really important, pointing out that this is not, these activities are not the product of the past year. You both identified the camaraderie of family, but also mistrust and a lot of other significant issues that are involved in really being able to engage underserved communities. So as you guys have gone through this process and you look at the gaps and the needs, what do you think are the most critical gaps and needs that other organizations could be looking to solve? And what's Boston Scientific learned over the years that would lead to advice on how to really move through some of those key gaps?
Well, I'll speak maybe just internally to Boston, and maybe Dr. Jaff can speak more to some of the medical close the gap aspects. Just like any companies, we're always trying to improve. If you look at our Black representation in the company, it's not where we want it to be, but nor was our women representation and women in leadership. But by making, as I said before, specific goals and measurements behind that, and educating our employees as to why it's important, really drove a lot of engagement in the issues. It's probably been catalyzed even further by all the events that took place in 2020. But some of the best practice, just some of the learnings we did. I remember when we first brought in our first large internship group from the Black engineering colleges, we hired about, call it 5 to 6 from maybe 10 of the schools. And we had significant dropout rate after about a year. We weren't as sticky of an employer, so we didn't get as much retention as we wanted. And then we met with the Black engineering leaders, and they mentioned to us, hey, you ought to hire like 10 or 15 from 5 schools. That way there's a bigger community right off the bat where these new employees will feel comfortable. And so we've had much more success and retention of our brand new intern by going to that approach. And also, people want to see the future. And I can recall many recruiting events. I may be in front of our maybe a Black engineering group, but when we bring our U.S. sales leaders, African American, or our general counsel is an African American, the attention and the retention and the aspiration for these employees to join increases tenfold, because they see themselves in the future as an opportunity to be promoted within the company. So clearly, mirroring your recruiting efforts and your employee base to match the employees you're trying to go after makes a lot of sense to do, difficult to do. But we've had lots of best practices on recruiting and retention, although we're still not where we want to be.
Shay, there are some sobering statistics out there that people have heard, worth just underlining a few, that speak to what Mike's discussing. So just during the COVID pandemic, wave one alone, people who were Black, Hispanic, other underrepresented minorities suffered at least twice as much from the severe manifestations of the COVID infection than their white counterparts. And the mortality rates in some urban areas were 3 times higher among underrepresented minorities than their white counterparts. Now, this is not a new phenomenon. In my world, for example, with peripheral artery disease of the legs, leg artery blockage, patients who are underrepresented minorities suffer way worse manifestations of this. They present to doctors later when options to manage them are often gone. Their risk of limb loss, amputation, is 2, 3, 4, or 5 times higher than in their white counterparts in the next zip code, not the next state or the next country. And the rampant ravages of diabetes, obesity, the risk of cancer in underrepresented minorities is oftentimes way higher than their white patient counterparts. So this is an issue that has been recognized not only among the healthcare professionals, but even groups like at the federal level, the Congressional Black and Hispanic Caucus, who looks to us as an important ally to make sure that we are putting these facts out there and doing something about it.
Dr. Jeff, I'll follow up on that. And of course, Mike, jump in anytime. I mean, you mentioned these are long-standing issues, but we are in the middle of a pandemic that's really exposed a lot of these issues. And are we at a point yet where there are new lessons that we're learning from the pandemic that we can take with us to accelerate closing these gaps on health disparities or even preparing for the next one?
You know, I think we're all trying to find a silver lining or two from this incredibly difficult time that we've all lived for personal reasons and obviously public reasons. You know, one of the challenges with this increased illness rate, severe illness rate, and death rate in COVID is that underrepresented minorities are in particularly risky environments, multi-generational housing, jobs that are frontline, where they get exposed to the public at way higher rates, and some of the public not paying as much attention to their safety as let alone their own personal safety. So I think we've learned a lot about the cultural, environmental impacts of this that go beyond formal healthcare delivery. But a silver lining on this is that many young people who have watched this unfold have decided to go into healthcare as a profession. And we're seeing increased rates of enrollment in professional programs like nurse practitioner, physician assistants, physical therapists, et cetera, because they want to be able to learn how to provide care for their own communities. And frankly, this is a really important transformative moment for US healthcare. And I truly believe that any initiative we can do to increase representation of professionals in the field that then go back to their communities will again build this level of trust. It's not a fast solution, but it's one that we're active in. For example, we've now given scholarships to schools like that in order to promote underrepresented minorities entering the healthcare workforce.
And also, maybe just to add to that a bit more, just to try to put even more fuel on the awareness. So it's great to see the commitment of younger people joining the healthcare force. But we've also tried just to highlight the disparity challenges even more. So we've run TV ads, we've run billboards in select cities, just trying to educate people driving by these billboards on the healthcare disparities. And so it maybe helps people think twice, educates those who are most impacted, and just brings more awareness and more fuel, because I guess take advantage of a crisis. And I think this is a great opportunity to drive greater awareness to these disparity issues that we're seeing, and we're trying to help do that.
So, Mike, I'll ask you a big picture question. You know, it's easy for the press, the street, all of us to want to categorize companies and look at Boston Scientific as a healthcare company. Given just the broad perspective on the issues we're talking about, do you still lead just a healthcare company, or do you see Boston Scientific as a much bigger player beyond healthcare?
I don't. We're clearly a med tech company that wants to grow and deliver appropriate financial results and please shareholders like most all companies do. And I do think most companies start and lead with the heart and do the right thing. But our responsibility, we talk on our values, our caring values. We want to care for help our patients, our employees, and our communities first. And we know we have an obligation ourselves beyond delivering great products and hopefully strong financials, is to impact the community in positive ways. It's not just a job. It's just what we try to do this for a living. We want to make great products. We also want to make an impact in the community, and it makes our employees proud. It helps us with retention and engagement, and it's invigorating. And we know we have lots of work to do here, but we try to take a stand on issues. And we're a pretty big company, but we're not a Fortune 50 company. but we try to make our voice heard and act on things, whether it be the Close the Gap initiatives, the clinical trial work that Dr. Jeff has talked about. We were trying to be more forward-leaning on our open letter on the George Floyd case. We've recently suspended our PAC, our government contributions, given all the turmoil in Washington. And so we try to, speak with our voice on doing the right thing in terms of these community engagement and things that we believe are core to our values. So beyond making products, it is our responsibility to lead and act on our values and not stay silent on things.
Shay, I would just jump in and say that as someone who's only been with the company a year, but having worked with this company as a researcher for my whole career, I kind of always knew what drove the company from a scientific and intellectual curiosity standpoint. But until you get behind the tent and actually see what happens, this is not just speak. I've met remarkable people who work for this company who have dedicated their lives to changing the public awareness and the outcomes of disparities in healthcare. And it is really a remarkable, palpable experience for me.
I do want to, definitely kudos. Obviously, Boston Scientific has been, one of the most robust members of Medical Alley for a long time. And we have board members that get to see your leadership up front. And you all have been front and center leading really important conversations, not just during this time, but as you said, historically. And so from the entire community and the patients you serve that we're all looking out for, a big thanks. So last question, and you can both jump in as we're winding down on time. Ultimately, these efforts have to lead us to, where we think we need to be. So are we getting there? And from your perspective, what does success look like for Boston Scientific?
With this, in this disparities area?
Yep.
I think success for me is when we have programs like Close the Gap, and they're being initiated by other companies, and the span of it continues to grow. Where many hospitals take on these initiatives on their own, where we're just one of many, whether it be the hospital leaders, other companies, this is part of their fabric, just like it is at Boston Scientific. I think that's when we really can scale this up, and we know we're helping to make a big impact when every company shares the same need to help with the disparities issue, and everyone on the street through our billboards or whatever else recognizes there's an issue and tries to make a difference in their community. So I think it's when you start seeing ultimately what you want to see these numbers change that Dr. Jeff talked about in terms of clinical trial participation, patients who are served. But I think taking this time now when there's an opportunity to pour more fuel on the awareness fire is what we're trying to do.
Dr. Jeff, what does success in tackling these challenges look like?
We just launched a large 5,000 person registry, Shay, and we've committed to a third to 40% of that population represented by these patients. I'll come back and tell you how proud I am when that target is actually hit. I look forward to meeting these new students who have enrolled in professional schools to become healthcare professionals. I think the discussion, the fact that we're all talking about it, I don't think this is a flash in the pan. I think it's now our time. And so I'm excited about that.
Well, I know our audience would love, as would I, to do this for a couple of hours with you guys. And hopefully we can do that at some point. But I really just want to say thanks again. You guys are doing amazing work, very busy. Thank you for taking the time to come on and share your perspectives and expose people more to the leadership that's happening at Boston Scientific. Dr. Jaff, Mike, as always, thank you so much. It's been a pleasure having you both.
Thank you.
Thanks a lot.
And for our audience, now I'm going to turn it over to my colleague, Bobby Patrick. Bobby is Medical Alley's Vice President of Strategic Growth and Policy, and Bobby will take us through the next part of our program. Bobby?
Great. Thank you, Shay. Appreciate the intro and great work with that first piece of this event. Hello, everyone. As Shay said, I am Bobby Patrick, and I am the Vice President of Strategic Growth and Policy for the Medical Alley Association. and welcome to the second part of our event today on increasing diversity in clinical trials. The panel today features leaders from Medical Alley Association members who are driving forward action on advancing inclusive research and developing external partnering strategies to increase diverse participation in clinical trials. Today's discussion will touch on what the barriers are, what are some strategies for removing them, and how industry can develop partnerships with each other and within the community to continue building the trust and positive relationships that will enable future growth and successes. So with that, let me introduce today's panelists. First is Melissa Gonzalez for External Partnering and of the Chief Diversity Office at Genentech. Hello, Melissa.
Hi, thank you for having me.
We also have Dr. Chaik Dalbeni, President or Professor of Family Medicine at Mayo Clinic School of Medicine. Hello, Chaik.
Thank you, Bobby, for having me.
And also Vino Raj, who's the Director of Clinical Research, Informatics and Analytics at Allina Health.
Thanks, Bobby.
Great, thank you. All right, so the first question will go to all three of you, but Melissa, I'll start with you. There's been significant discussion about increasing the diversity of clinical trials for quite a few years now. And the two leaders from Boston Scientific touched on this quite a bit during their part. But the interest has certainly ticked up significantly in recent months. What is one of the biggest underappreciated challenges to making progress on increasing the diversity of clinical trials?
So it's multifaceted. The challenges are at the systemic level, the study level, the patient level. So when I say systemic level, we're talking about the mistrust issues that we have been discussing today. We have lack of hospitals that have clinical infrastructure in areas where there are underserved patients. So when that's systemic, just a few examples there. When we talk about at the study level, what I focus a lot of my work on is when we're writing clinical trials, we need to be more intentional about the type of trial that we're designing, really scrubbing that protocol for bias. We use a lot of standard inclusion and exclusion criteria that are based off of Caucasian males from 20 years ago. We as sponsors need to do a better job looking at what in reality needs to be in our inclusion and exclusion criteria. We also need to do a better job making sure that our trials incorporate transportation issues to help patients overcome out-of-pocket costs. I think we often assume that, oh, if it's a clinical trial, everything's covered. That's not the case. What about parking to park downtown for patients? So as sponsors, we need to incorporate all of these issues into the study barriers. And at the patient level, we need to invest in communities. If it's the first time a patient has heard of us when we have a trial, we're doing something wrong. We need to invest in communities with sustained engagement, and most importantly, in a culturally sensitive manner. We can't assume that just because we're translating something into Spanish or into a different language that it resonates. We need to invest the time in talking to patients and doing more listening about what they perceive are the barriers to healthcare and to clinical trials.
Very good. And Chaik, I'll go next to you. And Melissa touched on three. Really put those into nice three areas there. You've done a significant amount of work in this space as well. So I'll turn the same question to you. You can answer Melissa, respond to Melissa, or on your own. What are some underappreciated challenges or ways of looking at the diversification of clinical trials?
Thank you so much, Bobby. I think it's really sobering to look at a lot of the struggles we've had historically to try to be inclusive in research. And yet, despite all of the things we've done, as amplified by Melissa, by Raj and Mike, we've not been very successful. And I think it goes back to something that all the speakers have talked about: intentionality, right? What do we want to do and how do we want to get there? So I think the really important thing that I want to emphasize, maybe re-emphasize again, is that we have to set goals and make objectives that we want to pursue and then stick with them. It's not a fly by night, because if we do so, it's not going to be successful. One thing I want to amplify that I've come to appreciate over time is access. And I speak about access from the perspective of really meeting people where they are. Melissa talked about the fact that we have hospitals that are not equipped, right, in the communities to actually enroll patients in clinical trials. And I'm one of the PIs of the NIH SEAL initiative. This SEAL initiative actually, in some ways, is a good example of what we can do, but also an example of some of the ways that we've not done things the right way. And give me a minute to explain why. NIH SEAL stands for Community Engagement Alliance Against COVID Disparities. And this was put in place or stood up because we realized in the middle of these trials that we're not accruing as many African Americans, Latinos, Native Americans as we should. And then our imperative was to now go in and change that. In many ways, I think it was successful. But to Melissa's point that I want to emphasize, we have to plan this from the start, and we didn't do so. So the first time people hear about a trial is not the first time that you go and want to recruit them to clinical trials. You have to engage them and include them in the planning and design of the trial. Be a partner in the community before you do the trial, and let them be a voice in design of the trial. Then they're invested, become connectors. One of the models we've used successfully in COVID is sort of generically can talk about it as a liaison or connector model. So we have community members who represent different aspects of a community who can then be messengers or trusted messengers going out into the community to do so. Let me talk briefly about access again, because I think it's really important to kind of, there are a couple of points I jotted down here. So I talked about location, the design, right? So how you design a study. Lots of the trials that I've seen, and we struggle with the same things that everyone has talked about. You know, you have inclusion, exclusion criteria that are not designed in ways to allow. So just because you don't speak English makes you ineligible for a trial. What do you want to do in your trial? You want to include people, then you have to be inclusive in those trials. And when implementing, again, I want to go back to having trials where people live. And so now we have technology. I'm sure it will come back to these topics. You know, how do we get to people where they are? What investment are we willing to make as society to make this be inclusive so that the research we do is going to be applicable for all populations? You know, so I'm going to put in the chat a viewpoint that actually just came out yesterday. It's from the U.S. Preventive Services Task Force. The struggle we have in the task force. And I'm going to at some point also add to the chat for folks to at least get to the NIH SEAL initiative website so you can look at some of the things we're doing. And one specific initiative we're working on is a tip sheet. We're happy to pass it on to a medical ally so you can share with your partners when it's finalized. Is what are the best practices that you can use, right, to design and implement your trials? And a lot of them actually, Dr. Raj talked about them. I think Mike and others talked about it earlier. And they go to the aspect of invest in the community, be there, be seen, be inclusive, report results back. And it's really important. And we'll share this with you once it's finalized. It's very soon.
Great. Thank you. Thank you, Chuck. Very, very insightful. Vino, you know, same question to you. You know, Alina has been really active in the space generally. And, you know, I know is doing a lot of work in clinical trials that it's helping to conduct. So what are your thoughts on the same question?
Yeah, I would like to build on what Melissa and Dr. Chuck said. I think it's establishing that relationship, establishing communication, establishing trust. Because at the end of the day, you know, if the community feels that research is a drive for exposure, rather than establishing or building on a trust that existed, it's never going to move forward. So what I appreciate that Alina has done is building on those connections that already has been made within the community to build the value proposition from there. Because if the community doesn't see the value of the research, there is no buy-in. So it is not something that we can start on when a research starts. It has to be built on what that relationship is, because we live in a world where everything is polarized, right? So information gets skewed so much. So if the community itself does not have that communication from their healthcare providers and their healthcare institutions, I believe, they don't trust in you. So I like to reiterate what was said throughout is, I think it's a process of building, it has to be a pillar foundation that trusts in the community rather than an afterthought. So, and I totally echo what Melissa and Dr. Chuck said.
Great. And so, all three of you talked about access. And so, I think let's go back to that for a little while. And I'll start with you again, Melissa. You specifically mentioned access, and Dr. Del Bene mentioned technology. And so, as far as access goes, what are some things that the healthcare industry can do overall in that space to improve the access to clinical trials? And then also, what role does technology play in helping to overcome that barrier?
Absolutely. So I think first and foremost, when it comes to access, we need to do a better job of looking at the clinical trial sites that we're using. Oftentimes it's, we'll go to the sites that we know can enroll patients the quickest. That's not the name of the game anymore. We need to change it and look for sites that are serving communities of color, that are devoted in this space. As we know that, many institutions like Mayo Cancer Center have a lot of devotion in this space and are developing strategies and are developing networks. And we need to make sure that we expand our horizons when it comes to clinical trial sites. And Genentech was able to do this with a recent trial called Impacta for treatment of COVID-induced pneumonia. We specifically went to community hospitals, non-traditional sites, to make sure that we were going to areas within the United States and global sites where patients were being disproportionately impacted by COVID. And as a result, we were able to enroll over 80% minorities into this trial. So it shows when you look for specific areas and you're intentional about reaching out and expanding your minds about who can run clinical trials, you can reach the patient and provide a service. And certainly when it comes to technology, as you mentioned, not only do we have to address the systemic issue that there is health or equity issues when it comes to broadband in communities of color, in underserved areas, but we need to invest in it in a collaborative manner so that we can take more trials to patients in these areas and say, you can do more visits now on phone or technology because you have internet access. So that's how we need to truly bring healthcare into communities.
Great. And Chaik, Melissa mentioned, intentionality as it relates to technology. Again, another area that I know you've done significant work in as well. What thoughts do you have about how technology can be used to overcome that issue?
I put myself on mute and began to talk to myself, which is not very nice. Technology actually is a double-edged sword, isn't it? Because the pandemic has told us, at least given us the opportunity to use telehealth in ways we haven't used in the past. And yet we know that the access and meaningful use of telehealth is not evenly distributed across our populations. The same populations, African Americans, Latino Americans struggled with access to technology and telehealth, especially in the reservations where this has been really acute. And we've been working with some to try to address these things. So there's really one, so we can't take all trials to every community. We can't take all trials to everybody, right? But also with the pandemic, there was relaxation of some of the rules around the use of remote monitoring, e-consenting, but these can't just be deployed and just be put out there, because if you do so, again, creates wider disparity in the community. So in addition to finding and actually resourcing local health systems, creating those partnerships, we believe very strongly in that, creating a partnership between local hospitals and large academic centers, because it's a way to sort of also build capacity in the community, right? If we don't do so, we'll still be ill prepared for the next pandemic. So as we build those relationships and the capacity in the hospitals, we're also with sponsors. And again, I wish we had these tip sheets ready. I would have sort of shot them to you, but we promise to share this with you. I think it has to multifold, but the technology is really important. Let me go back to it for a minute. If we want to use remote patient monitoring, we have to have navigators, technology navigators, people who can support them in using that technology, because some may be less educated, right, than the folks in sort of the wealthier neighborhoods, the zip code, one zip code over. And so we have to have navigators to do so. So going back to Melissa's point, I want to echo. We should change our view from rapid accrual, just because it's convenient, to one in which we want to intentionally accrue diverse populations to do so. So I would implore industry leaders to think about deploying technology and do it in a way that is sensitive to the needs of the community, address the cultural needs of those communities, have support systems in place to do so. Again, we can't boil the ocean or launch this overnight, but we have to perhaps invest in pilots and see how they succeed and build on the lessons learned, because you learn, you improve, you learn, improve. And I'm confident if we do so, we can get there.
Great, and that's certainly something that I think we will come back to as this goes along. Vino, same question, but then also, we've talked about the importance of establishing the relationships ahead of the research. And so, and that's something specifically you mentioned in your last answer. So, in addition to talking about technology and, leveraging that to increase participation, maybe share, how Allina has leveraged its existing relationships to improve the research it's been able to do within the communities.
Yes, Bobby. So I think for me, technology is almost three-part, right? A technology should not be an afterthought. So I think technology can be used in the initial patient identification, and not only in the patient identification, but that technology needs to be partnered with the trusted counterparts, which is your healthcare providers. At the end of the day, still all the data shows that your most amount of recruitments come from where those trusted sources are, and that trusted sources are your healthcare providers. And I think Allina has done really well whenever we have needed to recruit. We work with those providers so that they understand what the research is, and they play a large advocacy with their patient group. So one is using technology to identify, but also giving that to where it matters, so that that patient population could be identified and recruited from. I think the second part is technology also can be used for recruiting purposes, where that knowledge is disseminated to the community itself. And how do we use that, and how do we build on the community partnerships that we already had? Like, we can identify what groups would be best, but if that does not reach those groups, that's where that dies. So when we had to recruit for our vaccine study and stuff like that, we already used the relationships with those community leaders that we had. And I think that's an important part to hit in, is how do we continue on those relationships that was already established, and before even the trial comes out, establish that, say, hey, this is coming out, this is the value proposition, this is how it'll help you guys as a community. Because if they do not see the value that it brings to them, again, like I said, they're not going to buy into that. It's just another, oh great, it's here, why do I need to participate? What value does it bring to me? Because historically, all the minority groups come from a perception that they have been used for it rather than there is a benefit for them. And I think that needs to be addressed in the community. And I think finally, technology also can be used for that. We need to learn what went right, and we seem not to use technology enough to understand the whole study flow, what we did right, what we did wrong, and how can we improve on that. So I think those are the three prongs, and I think that's what Allina has been doing to make sure every single time we do the study better.
Very helpful. And Chaik, I see that you want to jump in on this, so go ahead.
Yeah, so this is So Panic is talking about something that I'm really passionate about, and we'll spend some hours talking about this. I think we're really, at the end of the day, talking about health equity, isn't it? How do we create a society in which there's equitable care, irrespective of where someone gets their care? And unfortunately, that's what the reality today. And the question here on the chat box is, different standards of care. And we know from our studies, and my work has been on colorectal cancer screening and a lot of other cancers that I've worked on. We know with a high level of certainty that where a person gets care almost determines their outcome, right? So there's sort of delayed access to care, but even when they get to care on time, the quality of care they receive is not equitable. So I think for us in society is, especially in certain clinical trials, is that how do we design it in such a way that they get access to the care afterwards? So one of the issues we've not touched on, and which is a real barrier, and Bobby, back to your question, what is one hidden thing that people don't know? In the setting of clinical, when they participate in clinical trials, do they see the benefits of the results in their community? One, but also if they find an abnormal thing in a clinical trial, right? Sponsors often provide this, but one of the challenges we find is that we do a study and there's something abnormal, then you're on your own. That leaves a sour taste. Do not hold a carrot to somebody if you're not going to let the person have it. So if you're going to do something, then let's take it all the way. So I think it's back to a point I made before. We're not, this problem can be solved. We have to be intentional about it. But one way to think about it is to make sure that there's no wrong door to the highest quality of care. It doesn't matter where you went, whether you went to the Federal Qualified Health Center or the Mayo Clinic. When you get there, you should receive the same quality of care in a timely manner, irrespective of whether this care was in a clinical trial or otherwise. And I'll close by saying this. I know as a Black man, I have one of the highest risks of dying from colorectal cancer. I'm reminded about that every day. And it's not because of my genetics, not at all. It's not because of my genetics. We all know why. And it's about providing the right access to care. And clinical trials can be a way to create that trust. But the important thing that I think all of us are saying in different ways is that we have to engage the community. We have to work with people, but not for them. And I would encourage people to think about that framework. Do not work for people, work with them, because it's a different way to think about this.
Thank you, Chuck. And you raised some really good points. And Melissa, I see you want to jump in here. And I think, I'll just add to this as well. Chuck mentioned the need to leave a positive feeling behind with the community. And so maybe you can also, in addition to building on Chuck's comments, talk about what are some ways that, sponsors and others can leave that positive feeling behind with the community. What are some things they can do to make sure that that stays there?
Yeah, so one of the things that resonated with me in this conversation was talking about, okay, we figure out how to get technology perhaps to somebody, then you need tech navigation. Same issue with if you get somebody in a clinical trial, that right there is a huge step in, because that means somebody actually sat down and took the time to talk to them about the informed consent. Who has access to their data? They already gained their trust in those initial steps, which doesn't happen a lot of times. And then you tell them, oh, sorry, you're not eligible. So my point is, as sponsors, we need to be more intentional with our site investigators, with our site staff, that you just don't throw somebody in a room with the informed consent and expect them to understand this. With a lot of cases with Latinos, it's a family decision. So you need to make sure you're sitting down with the family, answering their questions, because they will then support or convince the patient that, yes, this is worth their time. And so that's the kind of investment in patients that we need to make, so that when they understand the benefits of clinical trials and then do participate, that they understand that this is a benefit to the community, that they're helping future generations of their community benefit from the science that they are contributing to. I think oftentimes they don't understand that my dedication to this trial, because it is dedication on a patient's part. It's extra visits, it's extra time, that this can lead to better health, not only for them, for their family, for their communities, but it's on us to do a better job of explaining that to them. And so when we have these collaborations and sustained partnerships, that's when you leave lasting impressions, because you didn't only impact the patient's mind, but you impacted the family. And the family then goes and tells the neighbors and tells, the community. So that's how you really start to change hearts and minds around engaging with the healthcare industry.
Very interesting. And I think, I certainly, talking about the cultural sensitivity is really important. Simply saying we want to increase diversity in clinical trials isn't as simple as just snapping your fingers. It's really important to understand the community that you're going into and being able to build on those relationships. And I do want to come back around to that again if we have the opportunity. I think that that's a really important piece of this. And maybe Vino, you can weigh in on that as well. Again, building partnerships. I think many think of it between the clinicians and the sponsors, and not so much the partnership between the clinical trial and the community, and the ongoing partnership that has to exist. And Vino, we've talked about this a few times in your answers, but I don't know if you want to build on what Melissa and Chaik have said, and then maybe you can also weigh in on how to create that lasting value within the community, so that as you come back, your research continues to improve.
Yeah, Bobby. I do want to. Yeah, I think it's really important that patients understand in research there is a big value that is to gain for them, and I understand. Like for me, research. The reason I love doing research is it acts as a vehicle for where medicine can be tomorrow. And when we bring these participants in, like Dr. Chaik said, they need to understand, hey, there is something valuable that they're going to get, and they're not going to be left hanging. Does that make sense? So that, they are coming out of that saying, hey, there is definitely a value proposition. And, throughout that, the research participation, from the very first to the end, that goal reiterated to them and shared with them, so that they feel they are getting something from that. I think that is something of a big value and asset through a research within Alina. We do a lot of research that is kind of care delivery research, which immediately goes back to improving the functionality that is provided to our patients. So for them to understand that, to see that, and recognize that, they do not feel like it is a carrot that's dangled in front of them with nothing that they're going to receive at the end. So I think that is a big part that hits very close to home for me. And then also to add to that, I think it's really important to understand that when an organization sets, and I like what Mike said in the earlier session, when an organization sets central goals, I think that echoes throughout every part of that organization. When there is central goals to say, hey, we want to have diversity and inclusion as part of one of our pillars, I think that flows within the system, and then that is part of the culture. So we drive in every way to set that as a goal, and then it's not an afterthought. It is central to whatever we do. So I think those two are very important for me, with that point in mind, Bobby.
Thank you, Vino, and that is an important point. Making too often adding diversity to the clinical trial becomes an afterthought. Oh, we need to go back and do this, and it's really important to have that be part of the foundational design from the beginning. And so thank you for that segue, Vino. That leads me to my next question, and I'll start with you, Melissa. You've worked with Chaik on some things here in the past, and so I'd be interested to hear from both of you to start. And again, we'll start with you, Melissa. What are some keys for developing a shared partnership between the clinician, the sponsor, and then also the community? How do you wrap all that together?
So one of the secrets to our success in implementing inclusive research principles in our clinical development programs has been that over 2 years ago, the Chief Diversity Officer, Quita Highsmith, she developed an Advancing Inclusive Research External Council. This is made up of 14 experts that are researchers, patient advocacy leads, that are oncologists, retina specialists, that have been focused on addressing health equity issues for many years. And what we do with them is develop strategies to talk about the tough issues, discuss about appropriate strategies that we can implement in our clinical trials, as well as how to reach the community. So we're not working in a silo. We're not making it just about the disease areas that we're evaluating. It's a broad spectrum of how do we truly look at this in a very dynamic, panoramic view. And as we have worked with this external counsel and listened to a lot of different opinions, a lot of different ideas, it has instilled confidence throughout the organization. This is how we include inclusive research principles, not only in clinical development programs, which is very important, but across the business. It needs to be implemented all the way from clinical trial design through commercialization. We are in a country with rapidly changing demographics. And if we don't acknowledge that, we are missing the boat, because it's all about serving patients, like we said, from the beginning all the way through once that trial has been completed and the data has been reviewed and it's now on the market. And so this is when you have sustained momentum, acknowledgement, and involvement that you can then start to make progress. Collaboration is the key there.
Shaik, do you want to build on that?
Not a lot to add to Melissa's excellent points. I think there's also a point that Vanny has raised on the chat that I think is pertinent to this conversation. And I think the key here is the concept that I like of collective impact, right? But also Melissa talked about the upstream and downstream. When we go to the community to say we want to do a clinical trial, oftentimes, predictably, they'll laugh at you, or probably, if they could, chase you away, right? Because that's the wrong approach. But oftentimes, the first thing that we'll have to address, and we found that out in some of our programs in Florida, is that they have needs that need to be addressed before we get there. And that means that you have to have a broad set of partners that you work with. It's not just a trialist, it's not just an academic institution, but I think one of the values we can create within industry is that there's academic partnerships, industry partnerships, and community partnerships. The relationship can be sort of in that tripod, can come from any direction, but one in which we're working towards a shared goal and vision. And that has to be central to it. And I'll offer to everybody that the shared goal and vision is that which the community identifies as important to them. And our goals are ancillary to that. And if we look at it from that framework, I think we're more likely to succeed. It'll probably take a little longer. You have to pay a little price up front. We found that in some of our community relationships. Dr. Brewer, one of the faculties here, she will tell you, she built a relationship with African-American churches almost with a sweat and blood, right? But she had to prove that she was trustworthy. And that's important. And the same way, the industry partner you're working with, at least from my perspective as a leader at Mayo, who is overseeing health equity work, it has to be clear that industry partners are aligned with what we're trying to do, right? Ultimately, we all want to do inclusive research. The evidence is incredibly important to us. As I participate in U.S. Preventive Services Task Force, we know that this is an area in which we hope you in industry can help us to create evidence and inclusive evidence in research to help inform our recommendations. We don't have it, but we can't get there by just trying to shoehorn this. It's just not going to work. So I think it's that shared vision, a shared purpose, but always with the lens that we look at what the community needs and address those in concert with what we want. So I'm talking about need and want, right? I think it's different. Again, I go back to with and not for, because when we go with that framework that we want to work with the community, it's different. And hopefully in the future, when we come back to the screens, we'll see a lot more diversity on the screens and even behind the screens as we do now, because I'm confident that when you look at the tops of organizations on these calls, it's not as diverse as it needs to be. And that to me is what we ever need to be.
Excellent. So, sort of shifting gears here a little bit, specifically related to COVID-19, the clinical trial that Alana worked on with J&J relating to the COVID-19 vaccine sort of has, the two barriers to overcome, high level, right? Vaccines generally, and then also relating to building inclusivity in the clinical trial. So maybe you can talk specifically a bit about the work Alina did within that specific clinical trial.
Yeah, and I think like you said, it's very challenging when it's something new, and then also making sure that we have the inclusivity and that diversity. And I do want to touch on something that we were able to tap on, a resource that we had that was very beneficial. Alina has a director of diversity and inclusivity, and being able to have someone like that was able to give us communication tools, strategic tools, various ways that we can engage with these diverse populations, I think was very helpful for a trial like the J&J vaccine trial. So I think so, like, not every company might be able to have a director, but if that is the focus, while you are planning for that sort of a clinical trial, you acquire that tools, because like Melissa said, it's not just translating a consent, it's how do you communicate, and that has to be at the starting of the trial. It cannot be when you're doing the consenting process, you just take the English translation, English version, and then just translate it to something. There has to be ways you communicate. In my past life, when I was consulting for different groups, like when you're targeting different populations, the language has to be reflected. I think there has to be more tools thought out in front that is a little bit more inclusive to this diverse group. So again, it goes to planning in the front, and in the front, I think again the planning should be between the sponsors, the care providers, the research groups, and also the patient advocacy groups. I think that is really helpful. Being able to have a patient advocacy or patient engagement for research already established, where you can run it by them and say, hey, how should we approach this? Where do you see the value proposition? How should we communicate that? So I think those were a few points that really helped us navigate the J&J trial, especially with the inclusivity.
Great, and that's I think you touched on we got a question in the Q&A about how for startups and new businesses to sort of navigate ensuring that they are able to build inclusivity into their clinical trials, and I think you noted a positive way they can do that through patient advocacy groups and other existing groups within the community that they can reach out to early on in the process, and they don't have to, not waiting until they're working on the clinical trial, even though they have less resources than larger companies might. So this has been a fascinating discussion, and we're running up against time, and I want to give each of you the opportunity to close. And Melissa, I'll let you touch maybe a little bit more on the COVID-19 work that Genentech has done. And I'll go to you first, and then we'll go to Chaik, and we'll let wrap it up. So before we go there, I just want to thank all of you for your time and insight here. This has been, I have learned a lot, and I'm sure our audience has as well. And we greatly appreciate it and look forward to continuing the conversation. This is something the Medical Alley Association is going to continue to work on and bring forward thoughts and leadership expertise on. And so hopefully we'll get the opportunity to talk again in the future. And with that, I'll let you each wrap up. Melissa?
Yeah, so my closing thoughts are that it is possible to reach patients of color. It is possible. We need to talk to them about the benefits of clinical trials and provide a service to these communities. We need to stop the myths out there that it takes more time, that there's too much mistrust. It's on us to work together. And that's why I love doing panels like this. I have ideas. I will be reaching out to Dr. Dubeni. How do we continue the conversation and share best practices? It shouldn't be about competition. It's about helping the patients of this country so that, like we've said, in the future, we can say, we're enrolling into clinical trials, driving scientific innovation for all patients in this country. And we can only get there if we work together. So I look forward to that.
Great, thank you, Melissa. Chaik?
Bobby, this has been a fascinating conversation. I've learned a lot from it. I think a lot of the insights that was shared earlier really invaluable. And I think the thing that strikes me is how our thoughts are all in sync, right? But also in the acknowledgement that we know solutions exist and we can be successful if we take an intentional approach. One thing I want to share is that I took actually a decision to participate in one of the vaccine trials. And I did so because it's easy to read about these things in books until you actually confront them. And one of the things that a number of things that I came away with was that the vaccine trials were in places that were removed from where people were trying to recruit lived. And they couldn't actually open new sites in place because of restrictions around the resources needed to actually do so. So, and of course, the consent form was actually very good, but very lengthy, and there wasn't a lot of support to complete that consent form. And that's just a couple of thoughts that I want to close with. And again, reinforcing that inclusive participation is important. We need it, we desperately need it as a way to create the evidence and the strategies we need to address health disparities. We can't really do without it, and we need these treatments. We need to approach this with the angle of community engagement and make sure that as we try to open trials or any studies, as a matter of fact, we started with the goal to be inclusive. And I can assure you that investments will pay off over time. At first, it could be slow, but it will pay off over time. Maybe try tandem strategies, do both. And I think over time, it will pay off, as Vino has mentioned. I'm also want to sell at least to this group. I don't need to pitch it, but I do want to do it anyways. Which is that we need to leverage technology, but leverage it in a meaningful and sensible way. We are in an environment where people are getting used to virtual platforms. People are very accustomed to telephones. We need to be advocates for broadband in rural areas, providing access to broadband in all settings, and engaging with communities to become comfortable getting care remotely. That could translate to enroll in remote clinical trials. What if somebody can sit at home, enroll in that low risk, medium risk clinical trial, phase 3 trial, consent at home, right? Do the RPM at home, come to a center to visit every now and then. Imagine that he wants a diverse clinical trial that is open in some area in the middle of the country, and he wants patients to travel, leave their family, travel to that site to enroll in that clinical trial, and then go back home. Are you kidding me? Anyway, thank you.
Thank you, Doctor. Vino, any closing thoughts?
Oh, thank you, Bobby. No, this was definitely a very interesting and informative discussion. And thank you, Medical Alley, for inviting me. I was really happy to participate. I think for me, the takeaways are, I think we have to consider investing in diversity and inclusion. It cannot be an afterthought because, the community needs to see that this is a value to them. And that means investing in building those communications, building those trust and relationships, because what we invest in today is what we are going to see in the future. And I think, we live in this culture where we want an immediate result that, sometimes, we forget that we have to really start digging now to see that value proposition come out later. And I feel research is an ideal tool to kind of establish that, because, research means, setting it up for the next go, the to come, right? I think we have a great value proposition in research, and I think it's all of us coming together in understanding that, coming together, working between the sponsors, between the health organizations, between the community partnerships, and between the patient advocacy groups. I think us working together can really make that difference. So thank you, Bobby.
Great. And I think from the closing statements, something that just was driven home was, the need for the partnerships to really concentrate on removing the barriers as one of the top things that they do. So again, thank you to all of you for participating today. Thank you for those of you who took the time to watch and submit questions. We appreciate it. And this will be available on the Medical Alley website soon. So share it with those who weren't able to join as this event sold out, and we look forward to seeing you all again soon. Thank you, everyone.